Hi everyone, this is Manal Zaman. Today I'll be going over our week 5 discussion, which is reading the randomized control trial that we were assigned. For this week, I chose to evaluate the LIFE randomized trial, which studied the effect of a 24-month physical activity intervention versus the health education on cognitive outcomes in sedentary older adults. The study, conducted by Sink et al., aimed to determine whether regular physical activity for 24 months would help reduce chances of mild cognitive impairment or dementia among sedentary older adults at risk of disability. And they compared that to older adults solely receiving health education. In this study, there were 1,635 participants, and they were recruited from field centers all over the U.S. And the population consisted of both rural and urban community members. The sample consisted of both men and women aged 70 to 89 years who were independently able to walk about 400 meters. The reason one of the eligibility requirements was that this population were not diagnosed with any degree of dementia or had any cognitive impairments. And they were recruited via mail, mass mail, newspaper, radio, and television advertisements. The results from past RCTs that focused around assessing the effects of physical activity on cognitive function are uncertain due to various factors such as smaller sample sizes, short intervention periods, and differences in cohorts and protocols, such as the intensity of physical activity given to the intervention group. For example, there were 2 smaller RCTs that found no benefit between regular physical activity and changes in cognitive functioning. However, there was a 6-month RCT that found a modest benefit between physical activity changes and cognitive functioning, and there was also the 12-month LIFE pilot study conducted before this current one that I'm analyzing, which found a correlation between physical activity changes and cognitive performance. This study was a single-blinded randomized controlled trial, which means that the researchers knew what the participants, which group they were assigned to. However, the participants did not know which group they were assigned to, whether it was intervention or control group. It was a 24-month intervention period, probably because the researchers saw some positive effects of the 12-month study and figured if they did a 24-month study, they would see greater benefits. The study had, the participants in the study, it was a larger sample size compared to past RCTs, and the participants were randomly assigned to a control group, which engaged in a 60 to 90-minute health education workshop throughout the 24 months of the study, and the intervention group received moderate physical activity, which included walking, strength training, flexibility training, and balance training. There were baseline tests given to participants in the beginning of the study, which included a series of cognitive tests that were also repeated at 24 months to measure any changes in cognitive functioning. The study was, the results of the study did not show greater cognitive benefit for participants in the intervention group compared to the control group. This could have been due to a series of reasons, such as having insufficient assigned physical activity. Maybe it wasn't intense enough to see any benefits in cognitive changes, or that any cognitive improvement gained in the 12 months may have dissipated by the 24th month. And another reason per the study could be that the population selected had higher level of education. Per the study, those with higher education have greater cognitive ability, so that's what they associated. They associated higher level of education with. Maybe the results, there weren't greater benefits seen because the participants already had, good cognitive functioning. And then the population selected maybe wasn't specifically related to cognitive vulnerabilities, and that's why there wasn't a great benefit in that either. Lastly, the participants in the control group may have also benefited in cognitive functioning due to the social setting and receiving new information on health education. To better assess the randomized controlled trial, I'll be going over 6 components of the assessment of an RCT, which include objectivity, internal design validity, threat statistical validity, construct validity, external validity, and utilization. In terms of objectivity, although this it's not related to the results of the study, the researchers did make statements in the paper, such as stating that the population characteristics were the same in terms of none of the participants had any cognitive impairments at all. However, according to the 3 MSE scores, which measure cognitive functioning, there were participants that scored, it was out of 100 points, and there were participants that scored 88 or lower, which may mean that there were participants that had some kind of cognitive impairments. The ones that did score 88 and less had to go through an adjudication process where there was a panel that discussed the cases, and there was a final judgment which ruled that the ones that scored that low would participate in the study through a proxy. So there's no telling if the participants answered any of the questionnaires accurately, since it was through someone else than the actual participant. In terms of the results of the study, they do not seem biased, especially since the study did not find a correlation between intervention group and improved cognitive functioning. So in this study, the researchers chose to study an elderly population to see if there are any cognitive benefits from physical activity. However, as I previously stated, they found no correlation. This could be due to the fact that the population was sedentary and much older, and beginning physical activity at that age could not have had a significant effect on cognitive ability versus if they had started becoming more physically active earlier in life. Per a study by Mandolesi et al., they found that physical fitness instead of physical activity may have more of an impact on cognitive functioning. Physical fitness is somebody that having physical fitness is somebody that's already fit and actively working out. Another component of the design that could have created implications on the results is the use of the health education workshops for the control group. Per the study, both cognitive and social stimulation have been shown to preserve cognition in older adults. Therefore, there is a chance that the control group also benefited in cognitive functioning from the health education workshops. That could have also affected the results, and maybe that's why we didn't see such a great difference in the intervention group. In the future studies, maybe they can study the impact of health education workshops among elderly population to determine if there's a cognitive benefit just from that, compared to those that don't engage in any kind of health education workshop. In terms of the threats to statistical validity, it may be possible that the small significance resulting from the treatment group could be caused by the control group showing similar benefits in terms of cognitive changes. Therefore, the study shouldn't conclude that there is no significance and should further study both treatment options in separate studies to see if there are significant independent results. So maybe we shouldn't rule out the fact that, changes in cognitive functioning doesn't provide any benefits. Changes in physical activity doesn't provide any changes in cognitive functioning. Another factor in the study is that the sample size was quite large compared to past RCTs conducted. According to the textbook, the most common statistical validity issue surrounds studies with smaller sample sizes, and they're more likely to result in insignificant results. So in terms of this study, the sample size was large and it was a pretty long controlled trial. So that rules out that aspect of the statistical validity threat. Regarding construct validity, I went back several times to read the paper and found that there was very little background information provided on the impacts or outcomes and how they may result in the hypothesis coming true, which was that physical activity changes can positively affect cognitive functioning. The study didn't go much into detail on how physical activity can impact cognitive health, although it was mentioned that there were animal studies conducted which found that exercise improves cerebral blood flow and neuronal functioning. But there's not much data conducted on human studies and how it can affect brain functioning in humans. And although in this study the results weren't significantly correlated, it is important to take this into consideration for future studies so that relevant impacts are sought. Because the impact and outcome are important to signify, because that's the basis of the study. For external validity, there was the pilot live study that I mentioned a few slides ago that was conducted within a 12-month period, and it showed a positive correlation between physical and cognitive performance and in the exercise intervention. The pilot study could have been conducted in a population with characteristics most likely to respond to the changes, and the sample size of the study may have also been smaller, so the results were affected more. According to our textbook, it's not reasonable to expect similar results from replicating a pilot study into a larger and more realistic setting. And another factor in the external validity was that in the control group, they were attending health education workshops. So there were other participants there. There were the instructors or the health education teachers there. And that social activity factor is also known to reduce cognitive decline. So that's another external factor that could have affected this study. Although the results were insignificant, the study can still be utilized for future research. As previously stated, the study highlights the potential of health education and its possible impact on cognitive functioning. And even though it was used for the control group, in future studies it can be maybe combined with physical activity and provided as one treatment method to the intervention group. And maybe those two together could show greater benefit in cognitive functioning. My overall assessment of the study is that the research and the data is still very useful. It doesn't seem unbiased. This information learned from this study can be used in future studies, such as maybe there could be a study conducted between elderly that are already physically fit versus sedentary elder adults, and they could study the cognitive functioning between those two groups and compare them to see, if being physically fit does have cognitive benefits. Another type of study that could be conducted is we can have a group of individuals that are given both the physical activity aspect and the health education as an intervention to see if those combined can also benefit cognitive functioning. And lastly, choosing a slightly younger population and seeing if providing any kind of physical activity changes to a maybe instead of 70 to 89 years, maybe do it for 65 until 70 years to see if there are any effects, and maybe do a longitudinal study for that population. That way you could follow them maybe for 2 years, or check up on them in 5 years to see if doing regular physical activity maintains cognitive functioning or if there's any kind of decline. Another aspect of the study is that the current study used a larger sample size, which reduces validity concerns. And it was a pretty long 24-month intervention period. And so in terms of that, the study did all right. These are the references I used in my assessment. Thank you for watching my presentation.